Hello, everybody, and welcome to ICMDA webinars. I'm Dr. Peter Saunders, the Chief Executive of the International Christian Medical and Dental Association, which brings together about 60,000 Christian doctors and dentists in over 80 countries worldwide. And today's webinar is a historic occasion because this is the 150th webinar that we've run since we first started doing them in the first weeks of COVID back in 2020. And today we're privileged to have Dr. Johann Ebenezer and Dr. Praveen Alexander speaking to us together on the subject of community mental health in low resource settings. Dr. Johann and Dr. Praveen are primarily involved with the design, development, and teaching of the postgraduate diploma in mental health and the certificate in community mental health at Christian Medical College Vellore, CMC Vellore in South India. And these are online distance learning courses for training doctors and other healthcare workers in mental health skills for primary care. They also help with the planning and the running of several other courses run by the distance education unit at CMC. They love teaching together and designing and developing distance learning experiences. So by way of introduction, Dr. Johann did his MBBS from CMC Ludhiana, another very famous Christian hospital in the north of India, and his MD in psychiatry from CMC Vellore in South India. He worked in Pada Hospital, Madhya Pradesh from 2014 to 2017, where he started a community mental health project called Project Shifa in 75 surrounding villages. And since then, he's been working with the distance education unit at CMC Vellore. And Dr. Praveen did his MD in physiology after his MBBS, and he also has an MSc in neuroscience from Australia. He also works at the distance education unit at Christian Medical College Vellore, South India, and his special interests are in designing and evaluating online and distance courses in medical subjects. So you're going to do this webinar together, and it's just a delight to have you here today. We really look forward to hearing what you have to say. Thank you.
Thank you, Dr. Peter, for that introduction. And our distance education unit at CMC Vellore works very closely with ICMDA, and it's really a pleasure to be on this webinar and to talk about this subject, which really both of us are very passionate about, community mental health in low resource settings. So we're really looking forward to this. And how we structured this is for about the first half an hour, we would be having a sort of presentation where both of us will be conversing with one another in an interactive manner, and we'll be presenting our basic model of how we go about training resources for community mental health. And after that, we'll be taking questions as well, and Dr. Peter will be moderating that. All right, so I think we'll get started. Shall we, Praveen?
Yes. Shall we start with the topic? Community mental health in low resource settings, three-pronged training approach. Johann, how much time do we have to cover this long topic?
Well, I was told we have 30 minutes.
30 minutes? Half an hour?
Yes.
How are we going to manage such a long topic in just such a short duration?
Well, that's the interesting thing. When you have a long topic like this, it's good actually to break it up into little sections and try and understand what each section of the topic means. Would that help?
Oh, that's good an idea. Okay, so let me try. Let's start at the beginning. Community mental health. Why community mental health?
Okay, so that's a good way to break up that topic. Community mental health is a new buzzword these days. Everyone's talking about it. It's become a very popular catchphrase. but we often don't understand what we mean by the term. So let me just give a little bit of history. I know we are short on time, so I'll contract it and make it as concise as I can. So I think we have to understand a little bit about psychiatry as a discipline first. For a long time, it was a very hospital-based discipline, outpatient clinics, inpatient wards, and that was the system. And before that, if you rewind a little bit, it was, isolation in places which were almost like dungeons at times.
The asylum era.
Yes. So, there's been a long tradition of it being a very institution-based or hospital-based specialty that has considerably changed now. And it's become more about managing patients in the community with their families, getting patients back to work, getting them to function well and integrate into their communities. And of course, go ahead and take the required treatments which are available as well. So that shift has been encouraged by the World Health Organization and by a lot of other bodies as well. A general shift away from institutions and hospitals into the community. So that's what community mental health is all about. It's about getting patients back into their communities and into their families and their setting.
Okay, that's good. So you've covered the first part. Now let's go to the second part, and that is low resource settings. So mental health in the community in the context of low resource settings. Again, I think you mean something when you mean by low resource. What do you mean by that?
All right. Once again, good split. So let's go into what we mean by low resource setting. And here I'm actually referring to a very specific meaning of low resource. I think we tend to think of low resource in multiple ways. I'm talking about it in a very special and a very specific sort of way, which I'll come to. Now, to explain that, I have to tell you a little bit of my history. Is that okay?
History?
Short, concise. All right. So I trained in psychiatry, as Dr. Peter had mentioned earlier. CMC Vellore is really a very large, tertiary or even quaternary level institute, very hospital-based. So my training was very hospital-based in that sense. Now, after I trained, I was, well, you could say fortunate or unfortunate, either way, but I was sent to a mission hospital, all right? Me and my wife, who's an anesthetist, we went and served in a rural mission hospital in central India at a little village called Padar. And so now I say fortunate because I thought it was a very good eye-opening experience for me. I say unfortunate because I was sent to a place which my training had not prepared me for. But I think overall the experience was extremely fortunate for me. And I think I really enjoyed the experience. So what I want to just very quickly say is that although it was a good hospital, most of the patients from the surrounding villages were not coming to the hospital for mental health problems. So what we had to do is, I managed to get a number of hospital staff who were available, who were community field workers and other things, train them in basic, mental health skills, in identifying a few patients, learning how to pick them up and refer them, and how to follow them up well. And using those basic principles, we could start a community-based mental health program in about 75 villages in that area. It's called Project Shifa, and it's still continuing there at Padar. And so that experience taught me about, the importance of training others. You can't do it alone as a team. I can't do this alone as an individual. And just to give you a bit of context, when I went there, I was the only mental health professional in 4 districts in the surrounding area. So that's like a radius of about 200 kilometers. So there wasn't anything else at that time. So just to give you a context of how that was, it's really impossible for one person to take care of things alone. And so we really felt the need of, training others to help out with that and training different sorts of people. They were all non-specialists. They weren't even doctors or nurses. They were basically lay healthcare workers. And they were able to do a great job in identifying, referring, and following up patients. Yeah.
Okay. Thanks, Johann, for sharing the Shifa, your history with the Project Shifa. I mean, yeah, that is low resource. One mental health professional in a radius of 200 kilometers for villages across 4 districts. Interesting, because when we usually think of programs, we think of resources in terms of infrastructure, funding, equipment, and so on and so forth. But here we are focusing on human resource, people trained in mental health skills. So interesting way of looking at low resource in the context of community mental health. Okay, let's move on to the third part of the topic, 3-pronged training approach. Again, why training?
All right. I'm glad you asked, and I think that's really crucial. I'm just going to pick up on something you said a few seconds ago. In mental health, the key issue is not really infrastructure, in the sense you don't need big buildings necessarily. You don't need heavy equipments or expensive laboratory technology or things like that. Interventions are quite cost effective. They sometimes involve medications which are often available and can be, easily obtained. A lot of the interventions are non-pharmacological. So the key issue is the availability of skilled manpower, and that is actually the crux of the problem. So unlike many other medical disciplines, when you want to start a community program in mental health, the first thing you need to think about is not buildings, infrastructure, and expensive interventions. But the first thing you need to sort out is your manpower and the human resources available. And specialists are quite scarce in many settings. And this is where training can play a very major role, because training different sorts of healthcare workers, upskilling them in certain types of mental health skills is really going to be the crux of your problem in community mental health.
Okay, so thanks for breaking that long topic. At least now there is hope that we can complete within the time. So it must be as simple as 3-step, 3-pronged, 1, 2, 3, A, B, C. Is that what we're going to look at now?
Well, as usual, I have some surprises for you. So shall we open up the slide there? Yes. I'm sorry, it's not as simple as a 1, 2, 3 or an ABC, but I've tried to keep it simple. All right.
Okay. I, R, F. Okay. 3 letters with 3 to 4 words. Let's start at the beginning. Okay, it's I for identify.
Yes.
And R is for refer or resolve.
Yes.
And F is for follow up.
Yes.
And I'm sure you're waiting to explain to us what these words mean.
Absolutely.
Okay, let's start with I for identify.
All right. So what we mean in identify is basically, you need to train people with the skills to pick up mental health issues. That's often one of the biggest barriers, because people don't know what to expect mental health problems often look very similar to normal emotional experiences. Like, depression often mimics sadness, anxiety mimics normal stress, and so on and so forth. So you often see some overlap there, and so it's often missed. So identification is a key set of skills so that people can, your manpower learns to pick up people with mental health problems in their community. So that's the identification set of skills.
Okay. Okay, that seems straightforward at least. Let's go to R, which is refer or resolve. 2 words. Interesting.
Okay, so this is the second set of skills, which there's a reason there's 2 words there, because there are different levels of healthcare people who might be involved here. For example, if you're a GP, a general practitioner, or a family physician, or an internal medicine person, you're actually in a position to manage a good amount of mental health problems. So you can actually resolve a lot of them. Sometimes you might need some extra training to pick up certain extra skills, particularly non-pharmacological skills and things like that. But still, it's well within your scope as a general practitioner to manage up to 70 to 80% of common and severe mental health problems. So there's a lot that can be resolved there. But there are other healthcare workers as well, nurses, community workers, and sometimes just lay people who want to help and get involved. They may not be all able to resolve everything on their own, but they can refer. And it's important to learn how to refer. That itself is a set of skills they need to have. They need to know when to refer someone. They need to know how to refer. That could mean things like, have I explained to the patient and the relatives why they need the referral and to whom I'm referring? It could mean writing a referral note. It could mean even accompanying the patient and family, if possible, for the referral and things like that. So there are certain referral skills, and sometimes even whom to refer to. For example, different sorts of patients might benefit from different kinds of referrals. Particularly if a psychiatrist or psychologist is not available, there could be other people also who could help, like a general practitioner, or if it's a child, a pediatrician, or a counselor who might be able to help. So just to know whom to refer to as well is an important skill. So that's the R component. It's either resolving, if that's possible, or referring. And even as a general practitioner, there'll be things you won't be able to do. You may want to refer to someone else. So you need to know when, you've reached the end of your limit of skills and to whom you can refer to for further help. So that's the R.
Okay, that we have reached to F, which is follow up. Okay, what do we mean by that?
All right. So I think the I and R are quite intuitive, It's what you often do with medical problems in general. The F is something that's quite unique because follow-up is probably the most crucial aspect of mental health care. Unlike, say, surgery or, ophthalmology, for example, a lot of the interventions are one-time. So even if you do identify a person with cataract, you refer, operate, and it's done. Or, something like a cleft lip or a deformity like that. Identify, operate, it's done. So not always, but very often the interventions are one time. But here nothing is one time. Unless there is good follow-up, often nothing helps. So it's such a crucial component of mental health work that it deserves a whole set of skills of its own. Again, as a general practitioner, you might be following up. As a community health worker, you may be, again, helping someone to follow up and checking that they're doing the instructions given by the therapist. As a lay person also, you might want to check on these things. So whatever level of skill you're operating at, follow-up is still something you can be a part of. And you can contribute to the overall, prognosis and the overall well-being of the patient. So it's a really crucial set of skills. So I think that's why we even want to give it its own letter in the model.
Yeah, okay. Interesting. We have given a lot of thought on which letters to use and what are the skills. Let me catch on something that you kept repeating. You kept repeating 3 set of skills. So why is it 3-pronged? And it seems like it's 3-stepped: identify, refer, and follow. Why is it not 3-stepped, but you have named it as 3-pronged?
All right. I think that's a great question. Well, from a certain angle, particularly from the patient's perspective, the 3 things are sequential steps. For example, if I'm a patient, I'm first identified by someone. Usually I'm, taken to a doctor or someone who sees me. It's either resolved or referred further, and then someone follows beyond. So that would be the patient's perspective. It is sequential. But from the healthcare worker's perspective, particularly in community mental health settings, it may not always be sequential. For example, let's say you're a GP. Somebody else has identified this patient at home and brought them to you as a referral. So you're starting the story at the R component. Either you resolve it or you might refer. Even if you refer to a psychiatrist, you might be involved in the F component as well, because you might want to check up on them and see if they're following the instructions, are they going regularly, and things like that. On the other hand, you might also be following up someone who's been seen by somebody else. Or you might be, resolving something that someone else has already identified and diagnosed and seen. So as a healthcare worker, you might be at different stages of this. So that's why we don't want to say it as, call it just sequential or steps. I would prefer the word 3-pronged, because these are like 3 tracks of skills we need to train people in. All right. You need to have your identification skills. You need to be able to pick up problems in the first place and appropriately diagnose them. You need to have your resolving or referral skills, depending on what level of healthcare worker you are. And you need to have your follow-up skills. So they're like 3 sets of skills or 3 tracks of skills, all of which are important for the person involved with community mental health. Although the healthcare worker may not be doing it in sequence for each patient. The patient, however, experiences it sequentially. I hope that makes sense.
Yes. So, and it's important that the patient goes through all of this. We may not be the person giving it all of the 3 tracks. The patient definitely has to receive all 3 tracks to be able to resolve and get out of their mental health issues. Okay, so that has been an interesting discussion. Quick side note question. So how did this all wheels come up? Did you have a Eureka Archimedes moment suddenly and all the wheels come up and 3 letters of I, R, and L? Was it a brainwave yesterday night?
Not really. I think this did not come up overnight, and it's not just 1 or 2 people's idea. It's been something in the works for about 10 years now. So ever since I've been at Padar and those days where we were doing the community mental health work in the field, the inputs there, the lessons learned there in training non-specialists, all of that fed into our later experience with the distance education unit, where we put that experience together into 2 courses. All right. And I think the work done with training different sorts of people is what helped us consolidate this model. So I think it's not that the model was created first and then the training programs came later. I think it was the other way around, rather. It was the field experience that led to the training programs being designed, and then the model coming out of that. So having said that, I think I should just explain myself a little bit. I mentioned the two programs. So we have one program, which is a certificate course, a short course, a certificate course in community mental health. Now that's targeting basically any person who's interested. You need to have just a 12th grade pass minimum. So you could be from any background. You don't have to be a medical person at all. So that obviously has a slightly lower set of skills, but still skills regarding identification, appropriate referral, and follow-up. So that's what that course deals with. There is a higher level course, which is a distance diploma level course in mental health, which is basically targeting general practitioners. And the idea is that GPs or other doctors could do that program along with a colleague from their workplace. Now, the colleague could be a graduate from any discipline. Remember, we're talking about low resource areas here. So we may not get, psychologists and occupational therapists and all these people there, but the general practitioner still needs help to see patients, and he may not be free enough to do all the interventions. So we're getting every general practitioner who joins the course to bring along another graduate who could be from any discipline. And they work together as a team. We train them together as a team, and we teach them, again, identification skills, resolving skills, because they have to learn to resolve a lot of the issues as well. Up to 80% of mental health problems can be resolved at the GP level. So we teach them those resolving skills and when they need to refer, and we teach them the follow-up skills as well. So you can see there's 3 levels of healthcare workers in this model. There's the lay person or the community health worker. There's this non-doctor graduate person, and there's the general practitioner. So 3 different levels, 2 different courses or programs, but 3 tracks of skills that all of them need to learn. So that's kind of like the idea.
And these training programs and these levels have the mental health professionals, psychiatrists like you and psychologists and other mental health professionals at the top of the tier, which completes the complete cascade of mental health services being provided.
That's right.
Okay. That's good. So, interesting, we have been able to cover this long topic short while. Before we leave, I think this is probably the question all of our audience has. So, this is a good training model, this is a good training approach. What is it that they can take away from today's discussion?
All right, thanks. That's great. I think it's important to sum that up. So I would think of 2 takeaways that I'd like everyone to go away with. One would be, when you're doing community mental health in low resource settings, think training. I think training is the key word, and it is the game changer in the story. Because when we are in low resource settings, remember, human resources is the low resource issue. So if you want to address that, you need appropriate training strategies. Now, that would differ depending on who you are and what your context is. Remember, this model was designed with India as the context, where general practitioners in general have not very good mental health skills. That's because of the undergraduate training being inadequate in mental health. That may not be the story in different countries. You might find even lower level of skills in some countries. You might have much higher level of baseline mental health skills in others. So you have to see the context you're in and decide what's the appropriate kind of training you as a general practitioner need, or others in your team might need. For example, you might be a good general practitioner, but you might still need some other health workers to assist you in doing community work. They may need that lower level of training, so on and so forth. Or you as a general practitioner might want to upskill yourself and learn some more mental health skills to resolve things better. And you have to check also about what are the referral pathways you have in your setting. Do you even have a psychiatrist or a psychologist? or do you have lots of them? Who would you like to refer to? So all of those are things I think you need to think about, and training is the key issue in that. So that's my first takeaway. The other takeaway I think is, remember the three letters, I, R, and F. Now, why I think these are important is, for a good community mental health program, you need all these three tracks of skills to be robust. You can't have a community mental health program which is deficient in any of these if you want it to be an effective one. Now, often a lot of the attention is given to awareness programs and reducing stigma, and to some extent on the I, the identification part. That's where a lot of the noise is. That's where a lot of the attention often is. But we find that the R and F components are equally important, sometimes more important. Because if you identify a person and don't know what to do with him, there's almost no point in identifying. So that's where often many community mental health programs fall short. Even if they resolve or refer, very few are concentrating on follow-up. And even if you do a wonderful identification process and a wonderful diagnosis and treatment plan, if there's poor follow-up, it all collapses. So I think all the three, sets of skills are equally important. So I would say that's my second takeaway, I, R, and F. Yeah.
Remember, all three needs to be addressed. That's right. Okay. One last question before we hand it over. We are talking to Christian medical and dental professionals. And I think this is where I'm going to take you to your area of interest, history. What can we do in this area, additionally, as being Christian healthcare professionals? How can we adapt it to our context also?
All right, you're touching a very sensitive nerve there, and I'm really happy about that. So I think a little bit of history, once again, very concise, important here. We often hear about the church having a great contribution to healthcare, and that is true in many diseases. Leprosy is probably the standout example, but that's not the only one. So many different diseases where the Christian church has played a major role throughout history in caring for people, even before treatments were available. Compassionate care, general, a good supportive environment, and non-medical approaches which were already being practiced by the church long before scientific treatments came in. Unfortunately, in mental health, that isn't the same story. Mental health and the church have had a very complicated relationship, unfortunately. In fact, there was a long period during which the church was responsible for even increasing a lot of the stigma. We all must have heard of the witch hunts and things that happened at those times. A lot of mentally ill people were persecuted and outcasted and really treated very badly and ostracized and all. Unfortunately, the church historically had a not very good role in that way, but that has tremendously changed now. In fact, you could even trace the birth of modern psychiatry to a failing in the church in taking care of the mentally ill. Because if you read the New Testament and even the Old Testament, the care of souls was a very important part of the ministry of the church. And the early church did that really well. But somewhere along the line, that got lost. And the whole discipline of psychology and psychiatry almost came up to fill a vacuum left by the church in this area. So in a sense, the church needs to reclaim this area and get back into the game. That's happening now. So a lot of pastors and pastoral care workers are now realizing the importance of mental health. And a lot of psychiatrists and psychologists are now realizing that pastoral care is equally important for their mental health work. So there's lots more going on there. So I think this is a passionate area for us where we want the church to engage more. And who better to facilitate that than Christian medical and dental people? So I think this is the right audience to get this in.
Yeah, yes. That's an interesting note to end with. So if there are some interested people in the audience, what should they do?
All right. So like I mentioned earlier, our unit has a very good pre-existing relationship with ICMDA. Dr. Peter and Josh and others are very much in touch with our unit. So we would strongly recommend, that you contact them and they can get you in touch with us, and we'll be very happy to help out in various different ways, whether it's discussing about how programs can be developed, whether it's offering training with our courses, or even designing other training for different contexts. Those are all areas we're very happy to help with, and we would love to work with ICMDA for to connect with people who are interested in these areas.
Okay, Johann, good job. You finished in less than 3 hours.
Told you so.
Okay, so with that, we would like to end this discussion and let's hand it over back to Dr. Peter. Dr. Peter, over to you.
Very enlightening, and we've got lots of questions coming in already. Now, you said a lot about the role of the church, particularly at the end, and particularly that the church has not always been helpful in this area, often contributing to stigma, and then your comment that in many ways modern psychiatry arose out of the vacuum created by the church not doing things as well as they could. So I wanted to ask you, first of all, anonymous question we've got here, but what's the role of faith leaders in community mental health? Do you put faith leaders, pastors, evangelists, church planters, and so on through your basic mental health training program? If so, how does it work out? How do you deal with the faith leaders in your area who might perhaps even not have a correct view of mental health problems? Can you talk about the role of faith leaders?
All right, thanks. So I think I'll give a few comments and then ask Praveen to add on as well. So that'll be how we go about it. So I think faith healers can play a very crucial role in community mental health, not just within the church, but even within other faiths as well. Largely because a lot of patients and relatives tend to look at mental health problems as spiritual problems. Again, because of the overlap in symptomatology, and mental health disorders often mimic normal experiences. So they often think these are normal human experiences or spiritual experiences that a faith healer or a counselor is the right person to go to rather than a doctor. So it's quite natural for people to approach faith healers. So this is where training faith healers, even in something like that basic course I had mentioned earlier, and simply how to identify people who might be having mental health problems, teaching them whom they can refer to and how they can help following up, will play a big role, because faith healers are really frontline workers in mental health. They often see patients long before the mental health people do, or even before the GPs do. I think that would be my first answer there. Now, coming to the Christian concept in particular, I think we need to get chaplains, pastors, and other pastoral workers to really be more comfortable dealing with mental health issues in their congregations, because the Christian church has a mandate to be involved in these areas. So I think it's really crucial for us to involve them, engage them, and also to sensitize mental health workers and GPs on the importance that these spiritual workers play in mental health. So that would be my answer there. Praveen?
And just to add to that, the fact that the church has a confusion of how to deal with modern psychiatry and where the psychiatry is being practiced. And I think that's where Christian medical and dental professionals, healthcare professionals, can act as that link between pastors and those involved in pastoral care and faith healers to be connected with the field of psychiatry. And because there is a sense of, skepticism or suspect of that this is something physical, but we deal with spiritual. And that sort of, unfortunately, there has been that fragmentation of spiritual, psychological, and physical things. But as we all know, we are one being, and we need to look at that person as a person made in the image of God. And I think that's where Christian healthcare professionals can act that link between bringing faith. And the pastoral care is very much involved with following up a person. It's very intuitive for a pastoral person and those in faith leaders to keep following up, which is one of the cornerstones of mental health and all. So they fit in very well. We probably, the Christian healthcare professionals, need to be the catalyst for bringing these two fields or these two areas together in a synergistic. So that would be my comment.
So do you train a lot of pastors, evangelists, and so on with your basic mental health course? Do you find there's a lot?
Yes, we do. The basic course is, we've just completed our pilot batch and we're now taking in new people. But even in the pilot batch, we did have pastors there. So I think that was very helpful. So we did see the need that they had, and we did see them, taking up the skills very well. Even in the advanced course, there were many pastors who've taken the non-doctor role as well, along with the GP. So we've had about 5 years experience in there, and we've had a number of pastors and pastoral counselors who've taken on that role and really found it helpful.
Great. There's a question here from Anne Thurston. Anne's a British GP who's been working in Africa for many years. In fact, I had the privilege with my wife working alongside her in rural Kenya a long, long time ago. So hi, Anne. Anne's now in rural Chad in North Africa, Sahel region. And she says, I've found the WHO mental health gap program very useful in assessing patients and training others to do so. But the nearest psychiatrist for us is 1,000 kilometers away. The problem here is that such patients are perceived as demonized and untreatable. Therefore, they're not brought in for treatment. Organizing a seminar to train healthcare center nurses in mental health gap, one was overheard saying, of course, they are not treatable. How do you overcome this thinking, even among healthcare workers who seem to have much more of a cultural or spiritual view of mental health problems than being able to integrate a medical view?
All right, thank you. Great question. I think I can speak with a little experience on this because the setting I worked in was kind of similar, where we had a very strong spiritual model of mental health problems. It was basically a tribal, very animistic society. So everything was attributed to demons or malignant spirits and things like that. So I kind of can relate to that. So when we went out in Padar and started seeing people, this was exactly our experience. Villagers were not willing to come to the hospital because they didn't see it as a medical problem. So what really helped us was going out to them. And that's what actually helped change a lot. The community health workers whom I trained there were local people from those villages. So they knew the village, they knew the people well, they knew the terrain well. They were accepted quite easily. So when they brought people and identified people, it was easier to get them to come and see. And I also used to go out into the community and see them. And similarly, that was our general approach then. So in a community setting, even if it's open air, people are not so bothered about confidentiality and all like they are in the cities. Even if it's an open air clinic, under a tree or in some school, they're quite happy to come there and speak. So they're a little less reluctant to do that. So that's one aspect. The other aspect is we found that once people started getting better, that was often the best apologetic for the whole model, rather than just teaching them about it and telling them. So this is one thing we often found. Once they saw a person with schizophrenia getting better, or a person who's been having seizures for years, getting back to work and seeing this dramatic change, I think that was a very good apologetic for the whole thing. And lots more people started bringing their family members with mental health problems after that happened, though it took a little time for that to happen. I think that's also very, very helpful way of going about it. And just one thing about MHGAP, I completely agree. MHGAP is a very useful framework. In fact, our training programs are quite in line with MHGAP. So I think it's a very good framework to use for training and managing as well.
Yeah. Just to add to one comment, I think we need to look at faith healers and spiritual leaders as allies to work with, rather than to be antagonistic with them. Yes, they may have differing views, but I think that actually helps us as healthcare professionals to integrate our faith, be it in the Christian space or in non-Christian other faith backgrounds also. We need to be that catalyst, again, as I had mentioned before, to bring these two disciplines and these two areas together. And we need to work with that. And in fact, through our training programs and our various other aspects, we had to do a lot of soul searching of our own theology and our understanding of how faith interacts with our spirit and soul. So those are things I think that's a mandate on us to find out how we can work together in this space. So that would be my comment.
Thank you. You talked about the courses that you run. So there's the basic course, which you've just started, for people without any medical background at all, just a basic level of education. And then there's the higher level diploma course for family practitioners who've already got a medical degree. I wonder, can you tell us, with the basic course, someone working in the community, what level of expertise would they have? And particularly with regard to your three-pronged approach, what sort of conditions would someone with this training be able to identify? And which conditions would they be able to treat or resolve themselves, as opposed to having to refer them on to someone with more training?
All right, I think it's a good question. So the two courses have very defined scope. So let me just try and make that a little clearer. So the basic level one, the certificate course, is designed for anyone who's finished 12th grade. So it could be anybody. You don't need to even be a graduate to do that. So it's designed basically to follow basic identification skills of some key disorders. Those key disorders are common mental health problems like depression and anxiety, and even people who have attempted suicide. Severe mental disorders, particularly psychosis and seizures. Those are the two we're following up in with severe disorders. Alcohol-related problems, age-related problems such as dementia in the elderly or developmental disorders in the young. And finally, a group of miscellaneous issues like women's health issues and domestic violence and stuff like that. So there's a miscellaneous group of things as well. So these are the key areas where these people would learn identification skills. They would also learn referral skills, like who, after picking them up, who's the appropriate person for them to refer to. This course, the basic level course, does not teach any interventions. So they don't learn any interventions at all, except whom to refer to, how to refer, and finally, how to follow up as well. So, for example, in an area where there's no psychiatrist or psychologist, they would be taught who would be the next level of people to refer to for each condition. For example, for psychosis, there's no psychiatrist, look for a good GP. or if there's a developmental disorder, no psychiatrist, try to look for a pediatrician. Or that's just to give an example. So they taught at different levels, depending on their context, who would be the right people for them to refer to in their context, and what would be the appropriate way to follow up each of these disorders we've mentioned in their context. So that would be the basic level course. Now the higher level course, of course, is different. There is a non-doctor in the higher level course also. The GP brings along a non-doctor graduate. Now the doctor and the non-doctor graduate in the higher level course are taught a lot more. And they're taught a lot of interventions as well, non-pharmacological interventions, as well as the doctor has a lot of medicine skills also taught to them as well. So I just wanted to clarify that.
Thanks. So just to come back to you on that, with the basic level course, it's primarily about identification of a whole range of mental health problems and appropriate referral. But at the higher level, and they may both be medical background or not, they are learning interventional skills as well, yes, which I would assume would include things like CBT, cognitive behavioral therapy, and the prescribing of basic drugs for anxiety and depression, that sort of thing. Would it?
That's right. A bit more than that as well, because they would be also learn, the doctors would also learn about prescribing antipsychotics, prescribing anti-epileptics, and of course, medications for common mental health disorders as well. On the non-pharmacological side, not just CBT, but skills that would be required for a range of conditions. For example, supportive psychotherapy, they would learn a little bit of psychoeducation. They would learn some CBT skills as well, and some other skills like motivational interviewing for alcohol users and things like that. So there's a range of non-pharmacological things that they would learn. And both members would learn those non-pharmacological skills.
So that's a very broad range of skills at that level in intervention. So taking your IRF model again, but with the R, someone who's done your higher level course, what kind of things would they not be able to resolve and would need to identify and refer on either to a psychiatrist or a skilled psychologist?
All right. So I think definitely anything that would require admission in a hospital against the person's will would be out of, we don't train them in those things. We only train them in outpatient management. So if there is a patient with psychosis or bipolar disorder who needs to be admitted against his will, not willing to take medications they're not able to manage, that would be a clear sign to refer. Again, if there are neurological problems that they are not able to manage, they would have to refer. If patients don't get better with their basic interventions, they would be encouraged to refer. Anything beyond what we've taught them, like for example, personality disorders or more complex things like that, we're not training them at all. So they just have to identify them and refer. Yeah. And among the severe disorders, bipolar disorder in particular, we would encourage them to refer for the long-term pharmacological management because it's pretty tricky. So these are some of the examples of things that we would say straight away you would have to refer. And we clearly teach them this boundary line of where they can manage and where they need to refer.
And if I can add a note, one is based on experience of working in the field of psychiatry. And the other thing is we have defined the scope based on the legal regulations that a general practitioner can do. So I think this provides us to define the scope of the level of training. It's not just about the topics that we cover, but I think it's important, even when people are thinking about training initiatives, you need to look at what is legally and the regulatory bodies allow at that level. What is the scope then? And that needs to be clearly told. And that's something that we do in our training programs. Very clearly define what is the scope of the general practitioner, what is the scope of the non-medical graduate, what is the scope of the, and that needs to be defined well, because we should not be doing something that is not legally sanctioned or within the context of regulatory bodies in the specific context.
So if I could just add a point there, this model has been actually done with the Indian framework in mind. So particularly when it comes to prescriptions and doctors' roles, it might need modification based on the country you're practicing in. So this is largely with the Indian context in mind. Yeah.
Thank you. Now, sadly, we've almost run out of time, and we've got lots more questions that we're not going to get to. But I did want to come back to you just finally on the question of drug treatments. And when you were describing the evolution of psychiatry, the move from asylums, then to hospitals, and then to hospital treatment. And we certainly saw this in the West in higher resource settings, when in the 1970s and 80s, these huge mental health institutions were, in a sense, put out of business when people would charge back into the community because they could be managed that way. And I've heard it said, I'm not a psychiatrist myself, but I've heard it said that psychotherapeutic drugs played a big part in that, particularly helping psychotic patients to function in the community without having to be institutionalized. And so I just wanted to ask you about this question of access to medicines. And again, Dr. Anne Fursden has raised this, someone else has as well in the questions, an anonymous questioner. But, in a low resource setting, what can one do in terms of pharmacological treatments for mental health disorders, both neuroses and psychoses? And are there limitations in terms of finance, access, patient beliefs about not taking drugs and only having talking therapies and so on? Could you just talk a bit about the role of medicines, particularly in the low resource settings such as you've been working in?
All right, thank you. I think that's a very crucial point. And as you rightly mentioned, it was the discovery of drugs that helped the community mental health revolution start. I mean, it couldn't have happened without that. So it is a very crucial component of the story. Now, having worked in a low resource area, I can again talk about my experience in this area. You don't actually need too many drugs to manage basic issues in mental health. It all boils down to, for example, 1 or 2 antipsychotics, I mean, depending on where you are in, 1 or 2 antidepressants that you should be able to get, 1 or 2 anti-epileptics that you would need to get, and maybe something like a sedative or a benzodiazepine from time to time. With this minimum armamentarium, you can actually manage the full range of mental health problems. So although I know when we look at literature and all, it's a little scary to think of the huge number of drugs that are now available, you can actually manage the full spectrum with a very small number of drugs. The WHO has a wonderful list of essential medicines, so I encourage you all to look at those. Now, why I'm encouraging this is because WHO essential medicines are things that most governments can have access to. So these are things which should be available, and you can write to governments, talk to them, and ask them to get these available. Now, if you're in a country that's not very resource constrained, all of these drugs are very easily available. And then it's a question of how you want to get them and the cost. Now, in India, we have an advantage that there are generally drugs are priced quite cheap. And this may not be the story in most places. There are, there's a maximum retail price that's imposed on drugs. And the drugs which I tended to use and I encourage people to use are extremely cheap. So in India, it would cost something like, 5 or 10 rupees a day for treatment, which would be something like 2 cups of tea a day in terms of cost. That's all it really takes to manage any mental health condition with the drugs available there. So even if it was not government provided, we could still manage with medicines that were not expensive. Now, this would differ from country to country. I know the situations are different, which is why I'm stressing on the essential medicine list. So you can all, it's freely available online, WHO essential medicines for mental health problems. Those are things we can even work with governments to make available easily.
Thank you so much. And it's a shame to draw this to a close, but we have to, because we're running over time now, and we've really been fascinated to hear Dr. Johann and Dr. Praveen addressing this subject of community mental health in low resource settings. So it just remains to me to say thank you again to our speakers very much for your time and expertise, and also to all of you for coming along and for your very good questions. We're going to be back here again on ICMDA webinars next week at the same time, where we have, believe it or not, another speaker from CMC Valor, Dr. Rebecca Zechariah, who I believe heads up the distance learning team, which you're both working for, will be speaking to us about promoting family medicine worldwide. And just a reminder too that the World Congress is coming up for ICMDA on the 20th to 25th of June next month in Tanzania, and there'll be a pre-conference there run by Rebecca and her team on educating in family medicine worldwide. So do make use of all those resources. We look forward to seeing you again soon on ICMDA webinars. May the Lord bless you.